Alright guys, I'm here in the x-ray room and I'm just going to prepare the room for our patient and the sinuses exam we're going to do. First thing I'm going to do is I'm going to wipe down the board real quick with one of these alcohol sandy wipes to make sure that it's nice and sanitized. And then I'm going to have my patient sit in the stool. It's a lot easier for me to kind of stand over their head and position their head if I have them sit down on the stool. That way I can overlook their head. So I'm going to measure the board approximately to where I think the patient will be about, which is I think about right there, and bring my tube down here, and it's going to be about 48 inches. So that's about 48 inches right there, and then we have our shield ready for the patient, and that's it. Asta, and can you tell me your first and last name, please?
Stefan Manfred.
And your date of birth?
26, 1978.
Perfect, you are a man. What's going on with you today, Stefan?
Sinus have been fluctuating between complete congestion to drainage like crazy for like the last 3-4 years.
Okay, 3 or 4 years, good. Alright. Alright, well, come on over here. We're going to have you sit down on this stool here. And then we'll have you facing the board, actually, right behind it. Start positioning Stefan here for his sinuses. I'm going to start off with the waters. So I'll have him get as close as he can there to the IR, and we'll hyperextend his neck back, and his chin's basically going to be at the bottom of that center circle there. The OML will be about 37 degrees angled to the IR, and I'll overlook his head here, looking at his nose, making sure that he's nice and straight here. And I'm going to set my marker right down here at the bottom of the left side. And this MML line will basically be perpendicular to the IR as well here. The central ray will be entering about the vertex of his head and exiting out the acanthion right about there. And then I'll be sure to columnize here to our 8x10 IP. And we have our shield here. And I would shoot that at about 75 kVp and about 8 mass for him or so. And the next one I would do from here is the PA Caldwell, so I'll have him back away a little bit here. And luckily we have a tilting grid here. We can tilt at about 15 degrees. His OML should be 15 degrees to the IR. So I'm going to go ahead and tilt it here. Alright, and then we'll have him, basically his OML, as long as his OML is nice and perpendicular to the center of the IR there. And I'm going to center the central ray near the vertex of his head as well, but exiting out the nasion this time. And make sure to columnize to our 8x10 there. And make sure that the marker is going to be in there. And then we would just shield. And I would shoot this one at about the same technique, 75 kVp, about 8 mass. The next one we would do from here would be the lateral. So we'll go ahead and have him back away, and I'll make sure to take the angle away, make this parallel again. Alright, and I'm gonna put him in the RAO position, so it'll be his right shoulder, and then I'll have his head turning in a true lateral position there. And IOML should be about perpendicular to the front edge of the cassette there, which that looks like it's about so there. And then I'll have him just get really close there to the IR, reduce some of that magnification, put a marker right here. Our central ray is going to be about half to 1 inch from the outer canthus. So I can see here that we just need to back them up a little bit. Right about there is pretty good. And we would set the shield here, and the technique would be a little bit lower than the PA or the waters, at about 75 and about 5, I'd say. And then the last one we would do would be the Smb projection. So with this one, we'll just go ahead and turn them around here. And I'm going to have him basically really hyperextend his neck, and the top of the head would be on the IR there. I'm going to center a little bit lower here. And IOML should be parallel to the IR. the central ray entering about 3/4 of an inch anterior to the EAM, which is about right there, and making sure we columnize. Putting my left marker here, and I would shoot that at about 75 and about maybe 10 mass, maybe 8 mass would probably do as well. And then we can go ahead, and of course I would shield as well right before shooting that. Go up there, and then we can go ahead and relax. The sinuses exams here. We're going to continue on to the mandible here, and we're going to start with the PA. So I'll have him turn around here, and we're going to basically have his nose and his chin touching the center of the board there. And I'm going to put this up a little bit here, just to make sure we're centered to the jaw there. So nose and chin touching the board there. The canthiomeatal line will basically be perpendicular as it is there to the IR. And right marker here. Put my marker in there on the right side. And then we'll have the central ray at about the level of the lips. Right about there, and we'll make sure to columnize here. We have an 8x10 in there, but we can definitely columnize a little more than that, since it's just the body of the mandible that we're trying to get. And so that would be we would shoot that PA at about 75 and about 5 kVp. 75 kVp and about 5 mass. And from here we would just go ahead and move on to the PA axial, which is the same exact thing. We're going to keep them right there. And we just put a 30-degree angle cephalic on there. Again, exiting the lips. And making sure that we shield our patient there, and keeping my right marker right where it's at. And we would also move the board up here to go up on you. Making sure that the IR is lined up with the tube, and we would shoot that at about 75 and maybe about 7 or 8 just because of the angle on there. And then from here we would move on to a axiolateral oblique. So we turn him around here, and we're going to start with his head in the true lateral position, and then we're going to kind of rotate it in about 30 degrees or so up there, kind of have him tilt his head inward. And our angle from here is going to be not 30 but 25 degrees, so we'll take a little bit away from here. And we would be entering about the angle of the mandible or the gonian, maybe pulling back just a little bit here, there, right there, and putting my right marker probably right up here, out of the way of the mandible body. And we would go ahead and shield him once again, and probably shoot this at about 75 kVp and 5 mass, a little bit less thickness when it's from the side. And then our last one we would do would be the Smb. So we turn him back around here and make sure that we get my tube nice and perpendicular, ready to shoot the Smb. So go down. And we just scoot him forward a little bit here. Have him hyperextend his neck again there. And the IOML once again parallel with the IR there. And the central ray for this one would be entering between the two TMJs, which are about that level right there. Right there. And get our shield here. Make sure that we're shielding our patient in perpendicular, right, shooting at the body of the mandible there, and I'd shoot that at about 75 and probably 8 or 10 because of the thickness that it would have to go through with this head. and then you can go ahead and relax now. And that would be our. We
have our waters view here. This is the one that I shot in lab. As you can see, there's evidence of proper collimation because we used the cone here just to reduce the radiation to any other body parts. And we have the petrous pyramids right here, and they lie right at the floor of the maxillary sinuses. These are the maxillary sinuses right here. And in this image, the petrous pyramids could have probably been a little bit lower. It looks like they're right at the apices of the maxillary sinuses, but for the most part, that was acceptable. I have my marker here indicating that that is the left side. And then we look at we know we're not rotated if we look at the distance between the lateral borders of the skull and the lateral borders of the orbits on both sides. So we can see the lateral borders of the orbits and then the lateral borders of the skull. And for the most part, that's pretty good right there. That's probably as good as it's going to get. The orbits and the maxillary sinuses are symmetrical on both sides. Pretty symmetrical there. We can see the maxillary sinuses really well. So here we have our PA Caldwell for the sinuses. As you can see, we have proper collimation here. It looks like they used a cone for this one here, and then we can see the equal distance between the lateral borders of the orbits and the lateral border of the skull. They look the same on both sides. That indicates that there's no rotation there. The petrous ridges are pretty symmetric on both sides there, and they both lie in the lower thirds of the orbits as they should be. The frontal sinuses are lying above the frontal nasal suture, and the anterior ethmoidal air cells are lying above the petrous ridges. These are the ethmoidal, and these are the frontals here. We have our lateral sinus. We have all four groups of the sinuses. We have the frontal here. We have the ethmoid sinuses here. We have the sphenoid sinus here, which is the one of greatest importance. And we have the maxillary sinus right there. You can see that the sella turcica is superimposed. There's no rotation there. And then the collimation could have been a little bit better on this image, but everything else is pretty good. The mandibular rami are pretty superimposed here, just slightly off. For the sinuses is our Smb projection here. As we can see, we have some proper collimation there around the sinuses that we need to see. There's equal distance from the lateral border of the skull to the mandibular condyles. So as you can see, the mandibular condyles there and there is equal, pretty equal on both sides. Maybe it's slightly off, but pretty good for the most part. And that indicates that the mid-sagittal plane is perpendicular and there's no tilt. The anterior frontal bone is superimposed by the mental protuberance, and that indicates that the IOML was parallel and that there was full extension of the neck. And the mandibular condyles here are anterior to the petrous pyramids, which are right down here. So here we have our regular PA for the mandibular body. Basically all you're looking for here is that the mandibular body is symmetrical on each side, and as you can see it is, except for in this picture there's obviously a fracture here, but for the most part, if it wasn't for that, it would be equal on both sides. And then we can just go ahead and move on over to the PA axial, which is pretty much the same thing. For the PA axial, you just want the TMJs inferior to the mastoid process. So the TMJs, which are over here, are definitely inferior to the mastoid processes, and the ramis are pretty symmetrical, as we can see here. Here we have the axiolateral oblique of the mandibular body. As you can see, we have the rami here, and then just the body of the mandible right there. And there's definitely we try to colimize as best we could here. We could have probably collimized a little bit better. This is the one that I shot in lab. And there's no overlap of the ramus by the opposite side of the mandible, and no elongation or foreshortening of the ramus or body. That looks pretty straightforward there. And we're shooting for that left side. So our mandible series is the Smb projection here. The distance between the lateral border of the skull and the mandible are pretty equal on both sides, which is what we look for to make sure that there's no rotation there. And then the condyles of the mandible are anterior to the petrosa. So the condyles here are anterior to the petrose, which are right down here, condyles. And then the symphysis of the mental foramen is extending almost to the anterior border of the face, and that's right up here, almost all the way to the anterior border of the face. And that's so that mandible is not foreshortened. That concludes our sinus and mandible projections. Hope you enjoyed the show.